So I'm presenting in behalf of Medicine One. My topic today is the vulnerable. So presenting, this is a 37 years old male. He's from Andhra Pradesh. He presented with chief complaints of fever for 1 week, yellowish discoloration of the eyes for 4 days, and breathlessness for 2 days. Apparently normal 1 week back when he started developing high grade intermittent fever with chills, and it was more during the night. He also noticed yellowish discoloration of the eyes for 4 days. He developed breathlessness on exertion, which was insidious in onset and was gradually progressive, and it progressed from MMRC grade 1 to MMRC grade 4 over 2 days. Had no associated chest pain or palpitations. There is no history of hemoptysis. Had no other localizing signs like dysuria, loose stools, or no other localizing signs. And past history, this patient had a progressive upper limb deformities and anesthetic skin lesions over the past 1 year. So had been recently diagnosed with Hansen disease and has been started on rifampicin, clofazimine, and dapsone 1 month back. He has no other known comorbidities. Personal history wise, he has no nil addictions, and family history is nil significant. So on examination, this patient is conscious and he was oriented to time, place, and person. The patient was tachypnic and was in distress. On general examination had pallor and was icteric, but there was no cyanosis, clubbing, pedal edema, or no lymphadenopathy. Respiratory rate, he was tachypnic with a rate of 38 per minute on room air. He was maintaining saturation of 86%, but his GCS was 15/15 and his blood pressures were 100/60. And there was no associated JVP elevation or no pedal edema. Systemic examination, respiratory system examination, and bilateral equal chest movements, but there was bronch over the left infrascapular region. But otherwise, other system examination was normal. So this was his initial ABG. His initial ABG showed his pH of 7.53, PCO2 of 19, PO2 of 92, lactates were 1.4, bicarb was 20.4, and his glucose is 143, methemoglobin of 24.8, and his bicarb was 20.4. And his initial blood investigation showed an microcytic anemia with hemoglobin of 10.5. He was severely neutropenic, leukopenic with a WBC of 200. His platelet counts were 1,43,000. Also had multi-organ dysfunction with an altered, with his liver function test total bilirubin and direct bilirubin was 15 and direct bilirubin of 12.16. He also had his SGOT and SGPT was 53 and 22, and also had an acute kidney injury. So reporting, this is a 37 years old non-alcoholic male from Andhra Pradesh. The past history of Hansen disease has been recently started with anti-leprosy medications. So he presented with 1 week history of fever, jaundice, and progressive breathlessness. So in this context, so what could be our differential? With this ABG, actually it has an clue to this diagnosis. Yeah, methemoglobinemia. Yeah, yes. So differentials, yes. So initially, since the patient was severely neutropenic, and he was recently, severely neutropenic and he presented multi-organ dysfunction. So the causes for severe neutropenia, either it is due to secondary to infections or either it is due to drug induced. So we sent blood cultures, we did an baseline investigation, we sent dengue serology, scrub typhus, ELISA test for leptospirosis, which was negative. His culture blood, 3 blood cultures were sent. One of the blood cultures which grew Streptococcus pneumoniae and Pseudomonas aeruginosa, and culture sputum also grows and CRO. His blood-borne viral screen was negative. And this is the series of his blood profile. Initially presented with an hemoglobin of 10.5 and which gradually decreased. And his WBC is also, it maintained, it was severely neutropenic and leukopenic. His platelet counts were also, he also had a thrombocytopenia. So other investigations wise, so vitamin B12 and folic acid, there is no, bone marrow, it suggested, there's no associated no infections. And biopsy also, it does not yield anything significant. So this is what I want to specifically mention about. So this patient is ABG had a significant methemoglobinemia and which reverted back after administration of a particular drug. So what is this methemoglobin? It is actually an oxidized form of hemoglobin. So in this methemoglobin, the heme ion, which is normally in ferrous form, it gets oxidized and changes into ferric heme ion. So this ferric heme ion, it has a less affinity to oxygen. So because of which it does not bind oxygen, leading to functional anemia. So usually, normally, the levels are kept low by an enzyme called cytochrome B5 reductase, which actually reduces the heme it maintains the heme in a ferrous state. So what are the causes for methemoglobinemia? Then we probed into either it could be due to a congenital or acquired, but most commonly it could be secondary to it is most common cause. It could be acquired, and it is due to some exogenous drugs. So exogenous drugs wise, anticonvulsants, antimicrobials like dapsone, nitrofurantoin, antimalarials like chloroquine, primaquine, and topical anesthetics like benzocaine, lidocaine, analgesics, antipyretics, acetaminophen, nitrate derivatives, all of which can cause methemoglobinemia. So in our case, actually the patient, since he is recently diagnosed with Hansen disease and has been started on dapsone, so the probable differential and probable diagnosis we consider is an dapsone hypersensitivity syndrome. So what is this dapsone hypersensitivity syndrome? So before going into it, I want to mention about about the mechanism of action of dapsone and why does it occur and who are more prone to and what can we do and what should we consider before starting a person with dapsone. This dapsone, it is actually an antimicrobial and also it has an anti-inflammatory effect also. It is used in a variety of dermatological diseases and leprosy, and it can cause, but it has many side effects like gastric intolerance. It can cause hematuria, hepatitis, multi-organ dysfunction, and most important and specific thing is it can cause methemoglobinemia. So how does it act? So this mechanism action is dapsone is actually a bacteriostatic agent. So actually it inhibits incorporation of PABA. So incorporation of PABA into folic acid, leading to so that is the enzyme which is inhibited as dihydroxyapatite synthetase. So thereby it inhibits incorporation of PABA into folic acid. So how this drug it gets metabolized by two steps. One is by acetylation, another is by hydroxylation. So both of which occurs in the liver. So the problem is with the hydroxylation. So what is when it gets hydroxylated, it produces some toxic metabolites like nitrosamines, and one among them is hydroxylamine. It is DDH-NOH. So this is the most common reason, which is causing several toxic effects. So this, as I said, it inhibits the incorporation of dihydropaba into folic acid, so leading to decreased purine synthesis and thereby affecting the DNA synthesis. So as a whole, it has an antimicrobial, it has an antiphlogistic effect, which is antimicrobial effect. In animal studies, it also has a minimal anti and pharmacoeconomic drug also. So adverse reactions, most common adverse reactions, it can present in a variety of sequences. One among them is it can cause DRESS syndrome. It can cause, as I said, dapsone hypersensitive syndrome. It can cause hemolytic anemia, methemoglobinemia. It can affect hepatic, renal, pulmonary, thyroid, and dermatological (SJS), and even toxic epidermal necrolysis. So why does this occur? So actually, the mechanism wise and pathogenesis, actually, it is actually unclear. But it was said the proposed mechanism and some of the studies they mention is it is because of a delayed hypersensitivity reaction. And they said it is because of type 1 and type 4 hypersensitivity reaction. So what is this dapsone hypersensitivity reaction? It is actually, as I mentioned, hypersensitivity. It is a hypersensitivity response to a drug. It is an idiosyncratic drug reaction, which means it is not dose-related drug reaction. It is not specifically dose-related. So it was first described in 1949 by Alday, Lowe, and Barnes. The incidence wise, its incidence is very low. Its incidence is 0.5% to 3%. And when can it occur latency wise? Even a previously sensitized patient can occur within 2 to 6 hours, but it can occur as late as 6 months also. The classical triad in this case is actually the patient has fever, they will have some exacerbation of the skin lesions, and also internal organ involvement, but they can occur in varying combinations as well as in sequences. So this severe internal organ involvement like hepatitis, pneumonitis can lead the patient to death, and it can occur at any time. So hence severe vigilance is required. And it's a life-threatening condition also. It has a mortality rate of 9.9% to 12.5%. So other differentials like DRESS syndrome, lepra reaction, SJS and TEN can also occur. But DRESS syndrome, they will have leucinophilia. Lepra reaction, they will have exacerbation of their existing lesions. They will have nerve involvement. SJS or TEN, they can overlap and they can have peeling of skin, Nikolsky sign, or so and so. So who are more prone? So as I said, the incidence is very low. The incidence is 0.5% to 3%. But the very important thing is there is something called HLA association. HLA B1301. And those who have an preceding hepatitis B infection, they're more prone to develop this dapsone induced hypersensitivity reaction. So the toxic metabolite, as I said, is it is hydroxylamine. It is actually produced by the enzyme called cytochrome P450. So some studies, they say that increased age, and if a patient has a pre-existing liver disease, for example cirrhosis, so this they will have less cytochrome P450. So because of this, they offer relative protection. But there are many lack of clinical studies. Those aforementioned protection speculation. So these are few of the few articles which shows the association between HLA-B1301 and Dapsone hypersensitivity syndrome. So in this study, they studied around 872 patients. In among these 872 patients, only 39 they developed this Dapsone hypersensitivity syndrome. So the summary of the studies, they said is HLA-B1301 is considered as a very risk factor and the strong risk factor, and the patients had a sensitivity of 85.5 percentage and a specificity of 85.7% as a predictor of Dapsone hypersensitivity syndrome. And its absence is also associated with reduction in risk. And also, they also concluded this HLA-B1301. This frequency allele is more among the Chinese and Southeast Asian countries. In India, actually, its frequency allele is 1 to 20% of Indians have this HLA-B1301 allele. So this is also a next study. They also did the same. And one more gene association which was found is HLA-CW0304. So this study also showed about 90% of patients who developed drug-induced hypersensitivity reaction had an HLA-B1301. And the dapsone tolerant patients, that is in this case, around 21 people only had drug-induced hypersensitivity reaction. Cases, only 6.1% of the people had HLA-B27. And next, this is also a similar study which showed an association between HLA-B1301 and dapsone-induced hypersensitivity reaction. And this is actually association of some other drugs which should consider. For example, abacavir, it has an HLA association of B5701, and phenytoin has an HLA-B association of B1502. So back to our patient. In our patient, the patient had methemoglobinemia, had an anemia, agranulocytosis, hepatitis, and a fever. Since the patient presented with methemoglobinemia, he was given one shot of methylene blue, but which followed by which his methemoglobinemia were reverted back. But since the patient was severely neutropenic and secondary to multiple infections, he had a blood-borne infection and had a CR1 in his sputum and also had a secondary infection. The patient succumbed to death. So the learning points is the patient started on dapsone for various indications. They have to be observed carefully. Dapsone induced hypersensitivity reaction can be mistaken for progression of the primary disease. So what do you have to do it? We have to immediately stop the drug. Prompt cessation of the drug is needed, and we should start them with steroids, and supportive management will lead to rapid recovery. And also, as I said earlier, the frequency allele, the frequency of HLA B1301 is more among the Chinese and Southeast Asian populations, including India. For a people to start with dapsone, it's prior they should be screened for HLA B1301 frequency, gene allele. So thank you.
So how do you think you would have prevented for this patient to have?
So before starting with dapsone, I think we should have checked for his HLA B1301 status.
So we, especially in since it's available, yes, HLA, you can do it if you want. You can do it, and if it has good sensitivity also. But I saw you have described very well about one part of so you haven't really talked about the duration, no? From starting therapy to when should we suspect hypersensitivity reaction? You didn't mention about when was he started on therapy and when did he develop his symptoms?
So I started 1 month back, sir. So within 4 weeks, he started developing symptoms.
Okay, what is the expected duration for DHS for
So normally, actually, according to most of the studies, they said within 3 weeks. But also they said it can occur early also. If there's previously sensitized, it can occur within 6 hours, and it can occur as late as 6 months.
So variably, it can happen within a week to 8 weeks. It can happen. I understand but what about agranulocytosis, everything? What do you think is the cause for it?
So we thought it is secondary to, sepsis and associated Dapson hypersensitivity syndrome, sir.
What are the other side effects of dapsone other than hypersensitivity reaction?
So Dapsone, usually it can cause multi-organ dysfunction, sir, first thing. So it can cause hepatitis and it can cause other dermatological conditions and pneumonitis and hemolytic anemia, methemoglobinemia, and even agranulocytosis have also been reported. The incidence is low, sir.
Yes, but every instance low, but still agranulocytosis is one of the dreaded complication of dapsone. It still can potentially itself can cause agranulocytosis. I think this patient have multiple side effects, complications, whatever dapsone can cause, he has presented with. So, any more questions from the audience? Okay, thank you.
Thank you.